So before going there, let's remember some basic concepts. Don't forget regulation in our body. There are many ways that our body has to regulate different variables. Okay, in some cases, we use some local control mechanisms that can be para-clean, auto-clean, and regulating things at the local level, like a city council. Okay, or let's say the homeowners association is regulating at the local level, the dean regulating at the local level, and there are some actions, many processes in the body that occur at a distance. Okay, we call that a reflex control that typically takes a long distance and can be done by the nervous system using wires, using action potentials, neurotransmitters traveling from different parts of the body to other parts, and also the endocrine system. Remember, this can get very complex if we start adding the immune system, if we start adding all these complex network of signals that occur in the body, the microbiota, for example, sending signals when there is an infection. Okay, so that's why we have this research branch that is neuroimmunoendocrinology, that studies everything together, how all these aspects interact. But we have to define what is a reflex. Okay, reflexes are processes that are stereotyped, that means always occur predictably, okay, in the same way. Okay, they are involuntary responses. Now that involuntary always needs a clarification. Okay, there are reflexes that we have control over them, okay, that we can either elicit or not. For example, someone is assessing our patellar reflex. We may hold it, we may contract the knee, the muscles, and not elicit the reflex. We may, in some occasions, feel that we need to cough. That is a reflex. Something irritates the airway, and we feel we need to cough. We may inhibit the cough. If it's a mild cough, okay, if it's a really, really bad cough, it's impossible. So there are many of these reflexes that we can voluntarily either inhibit or exaggerate in some cases. Okay, these reflexes will occur typically as a result of one specific stimulus. Can be light, can be touch, can be different types of stimuli. And we're going to be seeing that there is always involved what we call a reflex arc. Okay, which there is an afferent pathway. Okay, there is a sensor that is connected to an afferent fiber, travels in afferent nerves. Okay, that fiber will go to interneurons in the central nervous system, and that interneuron will send a signal to effectors that can be muscles, can be glands. Okay, so we're going to have these arcs with these components. The sensory organ that is a receptor, for example, the retina. When you study the specific reflexes, okay, pupillary light reflex or dark reflex, that corneal reflex, okay, different reflexes that occur, deep tendon reflexes, okay, all of them will have a receptor, afferent nerve, integration center, efferent nerve, and then effectors. And I have here, while you were doing the quiz, I was doing this. This is something that I normally write on the whiteboard, but students were on that side are not going to see. I was doing this so everybody can see. This is the normal pathway that we study. When we start studying the reflexes, we know there is a receptor, the efferent fibers, interneurons that integrate, okay, those signals, and then send a signal out to the effectors. That is a simple pathway, okay? But things can get more complicated in the nervous system. So I'm going to give you the example of one reflex that normally we don't explore, and it's not hard to guess why, and it's the corneal reflex. Okay, something that you may explore if you want to know if someone is dead or not. I was done many years ago, before there were electroencephalograms, electrocardiograms, other ways of determining if someone is dead or not. They would put lemon in the eye, for example, or something like that. see if the eyes respond to painful signals. And it's not going to hurt if they are really dead. And if they are not dead, they are going to wake up. Hopefully. So in the case of the corneal reflex, for example, we have tactile receptors in the cornea, very sensitive receptors. You don't want anything in your cornea. Okay, the signals are going to be transmitted through the trigeminal nerve. It takes tactile information from the face, okay, including the cornea, including the tongue. That is a question that I've seen many times in exams that ask about the patient is having a procedure in the mouth, and the practitioner touches the tongue with the tongue depressor. Which of the following transmits the signals, okay, to the sensory area? And many students choose the facial nerve or nerves that transmit gustatory, okay, taste sensations. Touch is not taste. Okay, that is the trigeminal nerve. Okay, when you study the tongue, you will have receptors that transmit the taste from the anterior two-thirds of the tongue, okay, and from the posterior third. Those are taste receptors, taste nerves. Now the tactile is the trigeminal. The same for the cornea, the same for the face. Okay, different branches, thalamic, maxillary, mandibular branches of the trigeminal. When you do the physical exam and you reach the part of the nervous system, you're going to explore the sensation, okay, in the three parts of the face. So now these signals go to the integration center, that is the trigeminal nerve nucleus, okay, and then notice that here we're going to have more than one integration center, because when someone touches the cornea, we need to close the eyes, okay, and there are two effectors involved there. Okay, we need to relax a muscle, that is the levator palpebrae superioris, that is the one that keeps the eyes open, the upper eyelid. So we need to relax that one. And then we need to close the sphincter that we call the orbicularis oculus. We need to contract this orbicularis oculus and relax the levator palpebrae. So we need to stimulate, okay, one muscle, okay, the orbicularis oculus, and relax another muscle. That is the levator palpebralis. So this trigeminal nerve nucleus will send signals to other two nuclei. One is the oculomotor nerve, and the other is the facial nerve nucleus to close the eyes. Everything in a fraction of a second. Okay, here you have the diagram. I don't like the colors they chose. I would have inverted the green and the red. That's the diagram that I found. Okay, we have here the cornea. When someone touches the cornea, afferent information travels through the trigeminal nerve. Okay, that is gonna reach the trigeminal nerve nucleus. That is how you have two signals. One that they represent in red. I would have used the green for that because it's the excitatory. That is gonna go to the facial nerve, and that's gonna close the orbicularis oculus. And the other is going to the facial, to the abducens nucleus, okay, and from there, to the oculomotor nucleus, and that's going to go to the levator palpebralis to relax it. Okay, so we can close the eye. So sometimes this gets really complex. And these are things that we can test in the patient by doing things. You don't need to touch the cornea to assess the corneal reflex. You can simply do this in front of the face. They're going to close the eyes. Okay? And we can assess that without touching the patient. So imagine that the same thing is happening inside our brain, in what we call the unconscious mind. Okay? One thought enters, one word enters, okay? The sight of something enters, and that starts stimulating things, inhibiting things, okay? And there are also reflexes there. So reflexes can be very simple sometimes, or very, very complex sometimes. Some of them are easier to understand than others. They are classified depending on their development stage. For example, some of them are innate. We are born with them, and then we lose some of them at certain ages, and then some others are acquired at certain ages. We acquire them. Okay, depending on the response, they can be somatic, okay, or they can be visceral or autonomic. The somatic ones can be superficial or can be deep. For example, cremasteric reflex, reflexes that you elicit by simply touching the skin, superficial reflexes, and the ones that we assess, patella, Achilles, these are deep tendon reflexes. Can be monosynaptic, only one synapsis. They are going to be very fast. The patella reflex, for example, there's only one synapsis involved there. It's a monosynaptic reflex. And then we have the polysynaptic ones, very complex. Sometimes, and you may imagine, for example, if someone is walking and we step on something, glass or something that may hurt us, we need to withdraw the limb from there. At the same time, we don't want to fall. Okay, so that reflex has to send also signals to the other side of the body. So I don't fall, I can maintain balance. Okay, we don't want to make things worse. And depending on the processing side, some of them are processed, the integration occurs in the spinal cord or can be in the brainstem. This is simply explaining the difference between monosynaptic and polysynaptic. Okay, this is the example of a monosynaptic. Notice that we have a receptor there. That is the muscle spindle. Okay, and every time we stretch that muscle, just imagine we are eliciting the patella reflex. We are hitting the tendon. When we hit the tendon that stretches the muscle, suddenly that will stimulate or activate the spindle, muscle spindle. That information is going to travel through the sensory nerve, or is entering in the dorsal root ganglion, in the spinal cord, and then we have the activation, okay, of a motor neuron that is going to produce a contraction of the muscle. So the stretch of the muscle will lead to the contraction of the muscle. Preventing what? Excessive stretch. Okay, trying to protect the muscle against excessive stretch. Then we have here an example of a polysynaptic reflex. Notice that instead of the muscle spindle, we have here another type of receptor, that is the Golgi tendon organ. It's a similar receptor, but instead of in the muscle, it is located in the tendon. Okay, and this is the one that protects the muscle against excessive contraction. Let's say we want to go to the gym and we want to show off and demonstrate that we are the best, and we take a very heavy weight and we try to lift that, and that starts hurting the tendon. The tendon feels it's going to separate from the bone or from the muscle, and that reflex will make us drop the weight. Okay, that's protecting the muscle against excessive contraction. And you have there the sensory pathway going again to the dorsal root ganglion and connecting with an interneuron. Notice that we don't have any interneuron there. That's why that is monosynaptic. And this is polysynaptic. We have synapsis 1 here and synapsis 2 here. Okay, so we are going to activate an interneuron that will inhibit the muscle. Okay, this interneuron is inhibitory. Okay, we are going to drop the weights. It's not going to allow us to continue trying to lift something that we are not trained to lift, any excessive force. Now this is the stretch reflex. This is the example of the monosynaptic. It's exactly the same that we saw before, but now you have the complete drawing. Okay, notice how the stretch reflex occurs. We hit the patellar tendon, that produces the stretch of the muscle. You have the afferent fibers taking those signals to the spinal cord. Notice that there is a single synapsis there. We activate the interneuron, and this the motor neuron, and this motor neuron is going to produce the contraction of the muscle. So relaxation or stretch is the stimulus, contraction is the response. When we look at other types of reflexes, we are going to see that they get more complex. Okay, we have again here the example of the patellar reflex, but now we are adding another connection that also exists there. Because for us to produce the response to the patellar reflex, that is the extension of the leg, we need to not only contract the quadriceps, we need to relax the hamstrings. So we need another signal for that. In the same way that you need to relax one muscle and contract another for the blink reflex, this also has to happen here. We are going to contract the agonist and relax the antagonist. Look how the connection is. We have the monosynaptic reflex that produces the contraction of the quadriceps, the same that we saw before. But notice how this, the sensory neuron, the axon divides in two. Okay, so part of this neuron is going to activate an interneuron that is going to inhibit the flexors, the antagonists. Okay, that's more or less, it's a simplistic representation, but it's how this phenomenon works. You simply produce that move. Okay, that response in the case of that reflex. And if we want to make this a bit more complicated, we're adding some components little by little. Here we have what we call the withdrawal reflex, pain withdrawal reflex. So what I was mentioning before. Let's say someone stands on a nail or fire or anything, glass, broken glass, anything that hurts. We need to lift that foot from there. Okay, that will produce, if you follow the pathway, you have the sensory fibers entering again through the spinal cord. You see then the sensory neuron divided into stimulating agonists, inhibiting antagonists, exactly as we saw before. But now we are going to have a neuron that cross the midline to do the opposite thing on the muscles on the other leg. Okay, if we flex agonists, we're going to relax. If we contract agonists, we're going to relax agonists. And if we relax antagonists, we're going to contract the antagonists. Okay, that is crossed extensor reflex to simply maintain posture balance. And this gets more complex, but we are not going to add anything else, because it's not only holding the other leg. We also have maybe to grab something, but that's now proprioception, cerebellum, vestibular system, so that gets more complex.
Can you explain that again? The antagonist and the antagonist and the antagonist.
In this example, for example, okay, you have a person that steps on a nail, okay, and the afferent neuron is going to divide into, is going to produce the stimulation plus, okay, of the flexor and the inhibition of the extensor. On the other side, okay, you see there is another neuron crossing the midline. You are going to have the opposite effect. Okay, if here we are contracting the flexor, there we are relaxing the flexor. If here we are relaxing the extensor, there we are contracting the extensor.
So basically what it's doing is telling the right foot to lift up and telling the left foot to
stand,
support the weight.
To support the weight, yeah. But of course, there are all other neurons that go up to tell the cerebellum, vestibular system, hey, we need to hold this entire body in place. Okay, and then we change the position of the arms, the body, or grab something if possible, or hold someone if they are around.
Extreme.
Okay, or scream, help please. Okay, depending on the situation.
Or an extensive amount of backwards.
Mm-hmm.
Is that typically the only time we see a cross extensor reflex?
This is just an example to explain you the concept. That occurs almost in every action. Okay. And remember, these muscles will contract and relax even if you're not using them for sure. Even if you're not producing movement, remember what we did with the tongue? When you're the same may be happening, okay, even without producing movement. Okay. Now we are going to see another kind of complex reflex. It's the pupillary light reflex. In the eyes, you are going to explore many reflexes. Pupillary light reflex, accommodation reflex, okay, the corneal reflex that you're going to separate by paralysis, you're not going to do it, okay. And we could explore the pupillary dark reflex as well. We normally don't do that. You could, okay. Well, this simply is what explains the reaction of the pupil, okay, when we are in dark conditions or when we change from a dark conditions to light conditions. Okay, the pupil is like, you have a photographic camera, okay, there is a diaphragm that you will open or close depending on the light. Okay, so you don't want a picture that has excessive exposure or that is too dark. The same thing is what our eyes do in order to protect the retina, the receptors from being burned by the sunlight. And this is established by a balance between sympathetic and parasympathetic nervous system. Okay, if you don't remember these aspects very well, I always think when I try to remember the actions of the sympathetic and parasympathetic, okay, the sympathetic is the fight or flight. Okay, I need to either fight or run away. So what I need in my eyes, more light or less? Do I need to see better or I don't need to see? So the sympathetic will open up the pupil. So more light enters. I can see better what I have around. Parasympathetic is digest, rest. So I don't need too much light in my eyes. I need to dim the light. So the parasympathetic will close the eye, the pupil. In the iris, we have two muscles. One is a sphincter, okay, that will, if you contract it, closes. So that is going to be activated by the parasympathetic sphincter, circular. And we have the radial fibers, okay, that radially exposed, so if you contract them, you will open the pupil. Okay, that is the one that is stimulated by the sympathetic nervous system. I was looking at, I don't know if I saved it here. I was looking at an animation, but probably I closed, yeah, I think I closed it. I think I closed it, I won't recover it. We have access to the history, maybe. So you can see the, it's just interesting. You can contract the pupil or dilate the pupil. See how the radial muscles get thicker when you contract the pupil, and when you dilate, contract, they get thinner, and it's the circular sphincter, the one that tightens up. Okay, so these sphincter circular fibers are innervated by the parasympathetic, while the radial fibers, the ones that open up the pupil, are innervated by the sympathetic nervous system. Now notice how complex this can get. Okay, the pupil size is determined by this balance between sympathetic, parasympathetic. And what are the receptors for that reflex? They're the ones that detect the light. The retinal receptors. Notice the difference with the corneal reflex. Receptors are tactile receptors for the corneal reflex. Now we have light receptors, okay, that will send the signals through the optic nerve, that is the afferent pathway, and that is gonna occur, okay, after the optic nerve sends the signals, optic chiasm, etc. That is gonna reach the midbrain. There is a nucleus there that is called the pretectal nucleus. Okay, and from there, notice how the fibers from this pretectal nucleus in the midbrain is going to send signals to two nuclei. One is on the right side. Let's say we are stimulating the right eye with light. Okay, the light enters, signals, action potentials in the optic nerve. to the pretectal nucleus in that side. And from that nucleus, we're going to have fibers going to the two sides of the brain. Okay, there's a nucleus, EWN, or Edinger-Westphal nucleus. Okay, so at both sides of the brain are going to receive fibers from either eye that we are stimulating or from both. We are stimulating both at the same time. Now, what is going to happen? The fibers from there, okay, are going to follow. Remember, we are putting light in the retina. We need to close the pupil. That is going to stimulate parasympathetic fibers. Okay, that are going to produce as the effect the closure of the pupil, the meiosis or sphincter pupillary contraction, following the cranial nerve number 3 or oculomotor. That, as you remember, is the same one that innervates the levator palpebralis. Okay, start making those associations. And here we have a diagram. There is a video included. Okay, you have here on the left side the parasympathetic innervation of the pupil. Okay, and you have here the cranial nerve number 3 nucleus. Okay, you have here the Edinger-Westphal nucleus. And all these fibers of the parasympathetic nervous system going, okay, to innervate the sphincter of the pupil. On the right side, we are including the afferent pathway, that is the optic nerve. Okay, and let's say if you follow the signals, for example, these signals are going to enter to the pretectal area in the midbrain, and from there we are going to have a bilateral projection to the two Edinger-Westphal nuclei, and from there you have the efferent pathway following the parasympathetic nervous system to produce the contraction of the pupil. Now when it's dark, something different will happen. Okay? The pupillary dark reflex is something that may happen simply because there is absence of light. We are not activating the parasympathetic, or may happen when there is a sympathetic stimulation. Okay? When we activate the fight or flight response. And that will lead to pupil dilation. The pathway, the neurotransmitters, everything is going to be the same. There is darkness. Now the retina informs, okay, following the optic nerve, informs the hypothalamus. Okay, that is going to send a signal to the spinal cord segments T1 to T2. This is something that we have to put together with the anatomy of the sympathetic parasympathetic nervous system. If you remember from previous studies, parasympathetic fibers arise in the brainstem, okay, and in the sacrum. Sympathetic fibers arise in the thoracic spine, part of the lumbar spine. Okay, so notice how these fibers from the hypothalamus go to the spinal cord to the T1, T2 levels. Okay, and from there we are going to have the sympathetic fibers, okay, that will travel, okay, to innervate the dilator of the pupil. Okay, produce the pupil dilation. And well, sometimes we don't need to activate all that bunch of neurons in order to produce dilation of the pupil. We can simply use eye drops, okay, to dilate the pupil. That is what we do when we are going to have our glasses, adjust our vision glasses or so. Okay, the radial muscle of the iris has alpha-1 receptors, okay, that can be activated simply during the fight or flight response. We are in stress, our adrenal glands produce lots of epinephrine. Epinephrine is going to bind there, and that's going to open up without the intervention of any nerves if it's not necessary. Or simply topical drops. And these drops may be, for example, you can dilate the pupil by using medication, okay, that stimulates alpha-1 receptors, or you can simply block the acetylcholine receptors. Okay, because acetylcholine parasympathetic is trying to close it. epinephrine, sympathetic is trying to open up. Okay, so if we block the parasympathetic, we use anticholinergic medication, the sympathetic is going to be free to maintain the pupil open because we are blocking the parasympathetic one. So here we have a diagram that shows all these complicated connections, okay, that we use for the dilation of the pupil. Okay, we are gonna start here at the level of the hypothalamus. Notice how, so just imagine before the hypothalamus, what we have is the absence of light. Okay, absence of light, that's gonna activate these neurons here, or simply any fight or flight response. We are scared. Okay, our amygdala gets activated because we are scared. Okay, and those signals go to the hypothalamus. We are going to have signals from here going to the thoracic spine. From there, we are going to have fibers from the sympathetic nervous system, sympathetic fibers that are going to, notice how they go up below the subclavian artery to make a synapses in the superior cervical ganglion. And from there, we are going to have a division. Some fibers go up, okay, following the internal carotid. And notice some of the fibers are going to be activating the superior tarsal muscle to open the eyelid. Okay, some other fibers are going to enter directly to the pupillary dilator muscle. Now, what about the ones here? Notice that some fibers are going to activate the blood vessels in the face, and some other fibers are going to activate the sweat glands of the face. So just by knowing that anatomy, that's those connections there, you may predict what happens if I turn on the switch here. I'm going to send signals through this wire here. Okay, that will allow me to turn on the kitchen, the bathroom, all the lights in that part of the house. What that means, I'm going to elevate the eyelid. I'm going to open the pupil. I'm going to produce vasoconstriction in the face. And I'm going to start producing sweat. All the responses that occur, okay, when we activate the sympathetic nervous system, fight or flight. And you also may predict what happens if someone comes and cuts here. Now, we can cut here. Any way in this pathway. If you know the action, you're going to know how to predict what happens if this gets broken. Okay. What is going to happen with the eyelid? Are we going to be able to open? No. It's going to be like this. What is going to happen with the pupil in that side? It's going to be dilated. Okay? So when someone is in the dark, they're going to have one pupil open and the other closed. No? What is going to happen with the blood vessels of the face? How do you think the face will look? Pale or red? Red. You don't constrict the blood vessels. Okay? And what is going to happen with the skin? It's going to be dry or it's going to be wet?
Dry.
Okay? And that is a syndrome that is called Horner's syndrome. That may occur, for example, in people who have lung cancer. A type of lung cancer that appears in the apex of the lung. Or have a lymphoma and they have lymph nodes compressing. Or they have a stab wound to the neck or a gunshot or any wound or surgery. Okay, lesions in that affect the cervical trunk. And there you have the two of them. Okay, you have the two of them. The same thing that we mentioned before, but you can see the two together there. And here you have how to interpret, or the basis of the interpretation of some of the tests that you're going to be doing in PD. Okay, you're going to be assessing the light reflex, the direct and the consensual reflex. Okay, shine a light on one eye, your hand here, shine a light, normally both pupils are going to constrict because of what we mentioned before. Afferent information enters and the efferent goes to both eyes at the same time. Okay, now you change to the other eye. Shine a light, both pupils are going to constrict for the same reason. But sometimes you shine a light in one eye and nothing happens. Or you shine a light and the other pupil is the one that constricts. Interesting. What could be the reason for that? I shine a light here and this one doesn't constrict and this one constricts.
Okay, but motor damage in the side that is.
In what? Afferent or efferent?
Efferent.
Efferent.
Motor nerve.
Because it's afferent, nothing happens. If this optic nerve is not working, light is not reaching anywhere, so nothing is going to happen. Now, if I shine a light here, and this one doesn't constrict, but this one does, the motor output for this eye is messed up. Okay? And that way you interpret the findings of the physical exam. Okay? What should happen? What happens? What should happen? What happens? Okay?
So the damage is to the same side.
In that case, yeah. Okay? So let's have a break. Okay? This is something that has to be digested little by little. Okay? Let's have a break. Let's come back at 2:15. Okay? 2:15.
Quick question. You said here that nothing
the one that starts at 2. The quiz that I made is the one that starts at 2. Once you make it, you're going to get the results. But this one, so your last question is not the same as the question. For example, if she sends me the one that I have here, like 20 is your name. And your last question is the second question. Aortic heart stands where? Like, where does the aortic heart stand? Stands or like, where does it sit? And it said like, oh, trachea, esophagus. Waiting in front of what? Yeah, the location of the aortic heart. Trachea. Yeah, I forgot though. They were long. I looked it up and it said, you answered it? I didn't. So I was reading it and like right when I was about to choose an answer, the time went out. I looked it up and it said trachea, but I don't know why it's trachea. That's trachea. Not the use nervous system. And let me tell you something. These are things that when we are teaching this, as you see there, we are trying to condense as much as possible and trying to convey using basic, simple concepts and giving examples. But this is something that is extremely complex. Okay? When you study something in medicine that seems too simple, it's because there is a lot of missing information, okay? And that has a purpose. If we add all the information there, you're not going to get anything, not even the basics. Okay, so understand that this is something that you learn little by little. Okay, you have to build one layer, then another layer, another layer, another layer, and one day, in 500 years, you will say, oh, I understand it now. Okay, so
I don't feel so
I
bad.
get it now. I know how a builder works. You know? And well, simply, this is something that also the classification and the discoveries change a lot. Okay, so we have to be trying to understand many things. They discover new things every day. For example, when I studied medicine, okay, it was only this sympathetic, parasympathetic. It was very simple. It is like balance. If one increases, the other decreases. The same thing. It was easy to study. It was a table. No. But now we have added the enteric nervous system to the equation. So we have another branch of the autonomic nervous system. That is the one that controls the intestines. Okay, enteric nervous system that has other types of neurons, other types of neurotransmitters, other stuff there, can work by itself. Okay, and if you want to be picky, there is also a nervous system in the heart that no one calls it like that, but could be called the cardiac nervous system. What is the conduction system of the heart? It's a nervous system. You have neurons or cells that are excitable, that are capable of generating electrical impulses, action potentials, that respond to neurotransmitters, epinephrine, norepinephrine, acetylcholine, and they decide what is the heart rate and the strength of the contractility. You have this conduction system of the heart that is very simple, the structure, but it's an independent nervous system. If you take a heart of one person and you put it into another, you simply put together the blood vessels and the hearts are beating because the heart is capable of activity without any nerves helping it. Okay, it has automaticity. And well, we have this autonomic nervous system. We are going to study here the classic one. When we go to GI, we are going to study the enteric nervous system. Okay, it's divided in sympathetic and parasympathetic nervous system. There are other names. For example, the parasympathetic nervous system is also known as cholinergic nervous system, while the sympathetic is known as adrenergic nervous system. And it's important to manage all that terminology, because when you read books, journals, and articles, you don't know what words they choose. Okay, and also when you move to the enteric nervous system, you're going to find, for example, when you study the innervation of the sphincters in the intestines, these sphincters are innervated by non-cholinergic, non-adrenergic neurons. What is the meaning of non-cholinergic, non-adrenergic? Well, neurons that make something else, like VIP, like other types of neurotransmitters. Okay, so we are going to get there. We are going to get to that enteric nervous system. Okay, and also we have to try to sometimes unlearn things that we learned in the past. For example, that when we are in the fight or flight response, the sympathetic is on and the parasympathetic is off. And if we are resting, the parasympathetic is on and the sympathetic off. That never happens. They don't rest at all. Now, in different situations during the day, one of them prevails, the actions prevail, and the other is like a little bit down. But they are always, okay, like in check and balances. okay, checking each other, balancing each other. There is no on-off, okay? Typically, and that is what most of the health is about, the parasympathetic nervous system should be the one that predominates the entire day. We should be the entire day under a parasympathetic stimulation, and that would mean free of any stress. I mean, we don't listen to the news, we don't look at the gas prices, we don't look at the prices in Publix or any supermarket.
We don't worry about our tests.
We don't worry about anything. We don't respond phone calls. Nothing. Okay. But well, that's impossible. Okay. There are things that we have to do. It's our duty. Okay. So we are going to have in certain moments of the day activation of the sympathetic nervous system. Okay, when we need to act quickly and we need to escape from a situation. Okay, we're going to have a rush of adrenaline from the adrenal cortex. We're going to have activation of the sympathetic centers in the brainstem that will increase our heart rate, respiratory rate. It's going to stimulate the liver to release glucose into the blood. It's going to stop the digestion. It's going to stop the immune system functions. It's going to stop reproduction, everything that is not required for survival. Okay, they normally are acting together, but they are like in this type of balance. So what we need to do to start understanding this? First of all, the anatomy. Okay, in physiology, we sometimes have to touch anatomy, okay, because it's necessary to understand the entire thing. Okay, we were talking before about the origin of the fibers of the sympathetic and parasympathetic, and there you have it in this diagram. You have the parasympathetic on the left, sympathetic to the right, and notice the origin of the fibers of the parasympathetic brainstem. Okay, in purple there, you have fibers to the pupil, oculomotor. You have fibers to the salivary glands, to the, for example, the facial nerve, glossopharyngeal, all these fibers that carry parasympathetic fibers to stimulate salivation. So we have the closure of the pupil, we have the salivation, we have fibers. Notice that now we have one nerve that goes to the heart, lungs, stomach, liver, gut. It's the vagus nerve. There was a joke about that when I started lazy. Because in Spanish, vagus means lazy. And to be lazy is the one that works the most. No? Vagus was yeah, that would be an explanation. Okay. Vagus, but the problem is that the origin of that term vagus in Latin, vagus means like extensive. Okay, that is like vast. Vasto. But when you speak in vagus terms, you're being too broad, too general, no? Too broad, extends, okay, about something. So that's probably the origin. There are many mistakes in terminology in medicine, you have to know. For example, how you explain that the cephalic vein doesn't go to the head, it's not in the head. You know what is the cephalic vein, right?
Yeah.
Okay. Why is the cephalic vein here and not here? Because when someone many years ago made the translations of books from any, I'm not sure if it was Arabic or any Persian language, there was a word, if I don't remember bad, was al-kafed or something like that, that means the outer one, and they translated as cephalic, and that's still there. Due to respect to the person who made the first mistake. I would still call it cephalic. Okay. So these are parasympathetic fibers, notice that cover up to the gut. And then we have other parasympathetic fibers arising from the sacral nerves, okay, that go to the bladder, promote erection, promote female genitalia to the clitoris erection, okay, and then we have, here we have the sympathetic. So the parasympathetic has a craniosacral origin, brainstem and sacrum. Sympathetic fibers, thoracolumbar origin. That's why when we study the dark reflex, usually dark reflex, okay, the fibers from the hypothalamus, they could go directly to the eye, but they don't. They go down and up. Okay, that's some things that we don't have an explanation for them, like the accessory nerve. It's one of the cranial nerves.
The spine.
Back. It goes down and then up. Why? I don't know. Nobody knows, probably. Now notice that we are going to have, if you study the functions, they typically are opposite actions. Constriction of the pupil, dilation, stimulation of the saliva, inhibition, so dry mouth, wet mouth, slow heartbeat. We were talking about the cardiac nervous system. We have the synovial node that typically generates impulses automatically, auto-rhythmicity, 100 times per minute. Okay, if you have a heart with no innervation, it will beat at 100 times per minute. Now, normally the vagus nerve is releasing acetylcholine there to slow it down. Hey, no, don't rush. Let's keep it at 65, 7.
But it's directly to the SA node.
To the SA node. Okay? And to the AP node also to slow the conduction from atrial to vein. Now, if we need to accelerate the heart rate, we simply reduce the parasympathetic innervation and increase the sympathetic. Now we increase the heart rate 110, 120, depending on the amount of stimulation. What about the airways? What do you need? Remember if you have difficulties with this, what do you need to fight or flight? More air or less? More. So you need to open up the airway. So bronchodilation with the sympathetic, constriction with the parasympathetic. Now, remembering that is the first step. Now, we have also to recognize that in a question. I can ask a simple question. What happens to the bronchi if we stimulate adrenergic receptors? Adrenergic is sympathetic. You stimulate, you need more air, or you can complicate questions a little bit.
Anticholinergic would be dilation.
Then,
Anticholinergic drug.
if cholinergic produces constriction, anticholinergic will produce dilation. Okay, so we can complicate these things a little bit. Okay, researcher is investigating a new medication that relaxes smooth muscle, blah, 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 blah. But it's the same. Sympathetic dilates the bronchi. Parasympathetic constricts. Okay. And what else? Well, typically the parasympathetic, remember, is rest, digest. So all the digestive functions are going to be stimulated. Motility, secretion, absorption, digestion, and storage of food. When we are digesting, we are taking all the excess nutrients in the blood to the liver, to the adipose tissue, to the muscle. We are storing. Sympathetic is the contrary. We stop the secretions, we stop the motility, and we start taking nutrients from the liver and adipose tissue into the blood that we need to fight or flight. We need sugar to move the muscles. Okay, what about the urination? When you are in a fight, you need to defecate, urinate. No. It's not a good idea. Okay? So, fight or flight response, sympathetic will stop urination, will dilate the detrusor muscle of the bladder and will constrict the sphincter. Okay, if we are under parasympathetic stimulation, now we can go to the restroom, no problem. Okay, now we relax the sphincter and constrict the detrusor. This is also the motility of the colon, defecation.
Professor, but what about when somebody's so scared of something? I mean, wouldn't that be the fight or flight response, but why do they wet themselves?
Why do they wet? That's an interesting question, very good question, but that has to do more with centers in the prefrontal cortex. The center that we have to not urinate, to control urination, because remember that is something autonomic. Okay? We have here in the prefrontal cortex a center that simply inhibits that we urinate in the place that is not convenient. Okay? When someone, for example, has a stroke affecting that area, they urinate. Only once, but they urinate. Okay? When we are under a lot of fear, okay, the amygdala, when it is activated, inhibits the prefrontal cortex, and that may lead to urination. Exactly as it happens in a stroke. So that has more to do with limbic system, prefrontal cortex, amygdala, than with the sympathetic parasympathetic.
Wait, can you repeat the amygdala part? Because my brain didn't get it.
Her amygdala didn't kick in.
When you are relaxed, okay, your mind is able to learn music, watch a movie, talk to friends. When you are under a dangerous situation, the only thing that your body or your brain is capable of or will do is escape or fight. So when we are in an emergency situation, the amygdala gets activated and shuts down everything else. No reasoning. You don't need to reason, oh, there is a lion, so maybe I go to the tree, or maybe I jump, or maybe I hide here. We don't have time for reasoning or taking or decision making that pros and cons. The amygdala fires, inhibits all the reasoning, intellectual, cognitive function of the body, and activates the motor cortex.
So then
Motor
why do you
cortex,
think-
sympathetic nervous system, go away.
So then why do you think? I didn't get the
Oh, in the prefrontal cortex, we have the center that inhibits urination. When you, doesn't matter how full is your bladder, if you're not in a convenient place, you're not going to urinate. When you're in the convenient place, plop, urinate. The amygdala blocks that. So anything can happen. Fight, flight, freeze, or
Peace.
Yeah.
okay. Oh, and they're not mutually exclusive. Okay. Now the last part is genitalia. Okay. Notice that parasympathetic, relax, is the one that produces erection in both males and females. Clitoris pains. The sympathetic promotes ejaculation and vaginal contractions, orgasm part. Okay, that's the balance in that part. And that's the reason why, for example, people with anxiety, stress, lots of cortisol, epinephrine may have premature ejaculation because of not being able to maintain the parasympathetic activity for a long time. Sympathetic takes over because of fear of performance maybe, and they have ejaculation. Okay, maybe 1 minute after they started having sex.
So that, I don't know if I'm mistaken, but I think that there's people who are paraplegic, but they still can, so
Oh.
because it's in the lumbar region, right? But then the sacral still works.
Yeah, yeah. But you have to maintain a continuous stimulation. You can stop the stimulation. Okay. That erectile dysfunction is very complex. It has to do with the dopamine, with all that sympathetic, parasympathetic. But yeah, that's possible if the sacrum is not affected. So now we have the summary of that, okay? Besides knowing the location or the origin of the fibers, there is something else we need to know. And it's regarding the neurotransmitters and the type of neurons that produce these neurotransmitters. When you study the somatic nervous system, for example, when we were studying the monosynaptic reflex, you have an afferent neuron that goes from receptors to spinal cord, and a motor neuron that goes from spinal cord to the muscle. Okay, here in the autonomic nervous system, we are going to have a single afferent neuron, but we are going to have two efferent neurons. Okay, so there is a synapsis between the two efferent neurons. That synapsis is located in a ganglia. Ganglion, which is a group of neurons or neuronal bodies in the peripheral nervous system. Okay, and there are different locations for the ganglia of the sympathetic or the parasympathetic nervous system. And they produce different neurotransmitters. That's why we call one cholinergic and the other we call adrenergic. Okay, but we are going to see that there are some exceptions to that rule that we need to understand very well. And there you have the general functions of the sympathetic nervous system that arises in the hypothalamus. Neurons arise from the T1 to L3 level. And there are different places for the location of the ganglia. We divide them into paravertebral and prevertebral, so sides of the vertebrae and in front of the vertebrae. We have the names of the prevertebral ganglia. You have the celiac ganglion. You have the superior mesenteric and inferior mesenteric. If you remember the branches of the aorta, they're exactly the same. Okay. Celiac trunk, superior, inferior mesenteric. And we have, remember, in this motor pathway or efferent pathway, two neurons. One that is the one that goes from the spinal cord to the ganglion, and another from the ganglion to the effector, heart, guts, etc. Okay. Notice that the preganglionic neuron releases acetylcholine. So this is sympathetic, yes. Releases acetylcholine. Doesn't matter that is the sympathetic nervous system. The one that releases acetylcholine, okay, is gonna be the postganglionic. Releases adrenaline or epinephrine is gonna be the postsynaptic neuron. Notice that the preganglionic neurons will release acetylcholine to stimulate nicotinic receptors, called nicotinic receptors because they also respond to nicotine. And the postganglionic neuron is the one that releases norepinephrine, okay, that will bind to adrenergic receptors that can be alpha or beta. Then we have the subdivision of alpha in alpha 1, alpha 2, beta 1, beta 2, but that is for later. And there is one exception in the sympathetic nervous system. Some postganglionic neurons release acetylcholine, the ones that stimulate the sweat glands. Remember the example before of the sweat glands of the face? Okay, when we have a sympathetic stimulation, the sympathetic fibers release acetylcholine in the sweat glands. And we sweat. That happens in the face, that happens in the palms, the soles, the axillary region. That's why when we have a job interview, oh my goodness, I have to enter. I'm sorry. And you feel, my goodness, you feel sweaty everywhere, very nervous. Okay, but that neurotransmitter that is released in these sweat glands is acetylcholine. So how do you apply that? What if I take an anticholinergic medication? Okay, that will block that. Okay, that will block that sweat. And to advance some pharmacology, there are medications that we classify as antihistamines that have anticholinergic silent. Try to keep the phones in vibration or in silence if possible. Okay, because that changes the focus. Huh?
Sorry, I interrupted.
Benadryl, for example, antihistamines that have anticholinergic action. Also, yeah. And they may produce sweat, dry mouth. Okay, they can block the sweat.
I know Botox is a different thing, but people do it in the axilla to control sweat. But it would not work as anticholinergic. It would work differently, right?
The action of Botox is,
It paralyzes the muscle.
let's say you have the action terminal. Okay, you have the action terminal here. You have a vesicle with acetylcholine or any other neurotransmitter. When the action potential gets there, the vesicle has to dock. There are some proteins that will dock with the postsynaptic membrane to release the neurotransmitter. Okay, what Botox does is it doesn't let that.
All the synapses.
The neuron release the neurotransmitter. It blocks the synaptic transmission there.
Like a calcium inhibitor or something, so that it doesn't go in as a...
If you block the sodium channels, you can block but we use Botox because it lasts longer than inhibiting the sodium channels. So that is for the sympathetic. This is the one that has a short preganglionic neuron. Okay, remember if the ganglion is the side of the spinal cord on the vertebrae, the preganglionic neuron is very short. Okay, and then you have a very long postganglionic neuron. You analyze the ones that go to the heart. Okay, the preganglionic starts, let's say, in at T2. Have a short preganglionic neuron that goes out of the vertebrae, and then from there, from the ganglion, you have a long postganglionic neuron that goes to the sinoatrial node, goes to the heart tissue. And here we have some examples of parasympathetic fibers. Okay, and some nerves and examples of things that they innervate. Okay, there are parasympathetic fibers in the cranial nerves 3, 7, 9, 10. Okay, and they are going to have a very long preganglionic neuron because the ganglia of the parasympathetic nervous system is located very close to the organ, target organ, or sometimes within the target organ. So the postganglionic neuron is going to be very short. Oculomotor, as we studied before, participates in pupil constriction and accommodation. Facial nerve innervates the parotid gland. Notice that the lacrimal, submandibular, sublingual glands receive fibers from the glossopharyngeal. Okay, so lesion to the facial nerve will affect only the parotid gland, not the other ones. And the vagus will innervate everything in the thoracic abdominal cavity except the bladder genitalia. So notice how here we have something that is very similar to the sympathetic. Okay? The preganglionic neuron in the parasympathetic nervous system produces acetylcholine that binds to nicotinic receptor in the ganglia. That is exactly the same as in the sympathetic nervous system. And then we have the postganglionic fibers releasing acetylcholine that will bind to receptors that we call muscarinic. Are also receptors for acetylcholine. That muscarinic comes from mushrooms. Okay, if you want to have any relationship in your mind, what is muscarinic from? It's from mushrooms. Mushroom. Okay, like fungi. And what else? So there you have the general actions of the parasympathetic nervous system that we already mentioned before. Now here we have the receptors. This is very important for pharmacology, not so much for physiology. Okay, when you have a test, when we make the test, for example, that will include all this first part, you may have a question. So if you decide not to study this, and you study everything else, you're going to do perfectly fine, because there may be one question touching this topic. And that's something that students need to learn how to do. Okay, how much I have to spend and what will I get? Because if I see, oh, this is, I don't get this. I think I need 6 hours to study that. How many questions I'm risking? One? No. For example, when I prepared for the USMLE, I didn't study genetics. Not genetics, no, psychiatry. No, because every time I answer psychiatry question, I answer, this is the other one. It doesn't matter if I study 1 minute or 1 year. It's always the other answer. Okay, I'm not going to study that anymore. There were many psychiatry questions. I did well. These are risks that we take. So we're going to be studying basically these 4 types of receptors. There are more. But for clinical practice, we did these, not only. Alpha 1, 2, beta 1, beta 2. Alpha 1, alpha 2, they are like counterbalancing each other. Alpha 1 typically stimulates things, and the alpha 2 slows down that stimulus. trying to prevent an overactivation. Okay, then we have the beta 1, beta 2, and we need to understand the location of these receptors, so we understand the actions of the sympathetic and the medication. Because you can give, for example, if you administer epinephrine, epinephrine binds to everybody. So everything is going to happen if you administer epinephrine. But you can administer beta agonists or beta blockers. It's going to affect only the beta receptors, not the alpha. And beta agonists and blockers are subdivided into selective or non-selective. If you administer a non-selective beta blocker, you block all the beta receptors. If you administer a selective beta 1 blocker or beta 2 blocker, you block only those, not the others. Okay, that's the basic principle that you need to understand for pharmacology. Okay, epinephrine stimulates everybody. Okay, now, for example, norepinephrine. That is the primary neurotransmitter that we release in the ganglia, from the presynaptic to from the postsynaptic neuron to the effector organ, stimulates all except beta. Okay, so we don't stimulate beta 2 receptors by sending signals through the nerves. If you want to stimulate the beta 2 receptors, you need to release epinephrine from the adrenals. And it's like reinforcing. Okay, normal basal sympathetic response will stimulate alpha 1, alpha 2, and beta 1. If you release more epinephrine from the adrenals, then we are going to add the beta 2 receptors to this. Okay? And when you study the medications, okay, we are going to study or divide them. For example, the agonists, the ones that stimulate the sympathetic nervous system, we divide them into direct or indirect agonists. What is a direct agonist? Something that binds to the receptor. There is an alpha 1 receptor, will bind there and will stimulate. The cell thinks that is epinephrine. It's a chemical. Or you stimulate the beta 1 or the beta 2 directly. Now we can stimulate the actions of the sympathetic nervous system not by stimulating the receptors, but indirectly by letting the normal epinephrine that we produce, or norepinephrine, okay, having it stay there longer. Normally when we release norepinephrine, we are going to take it back to the presynaptic membrane. That's called reuptake. We can block the reuptake. No, where are you going? Stay there and keep stimulating the receptor there. Or we can stimulate the release of more epinephrine. For example, when people take drugs of abuse or medication to treat depression, okay, what they do is through different mechanism of action, stimulate the release of more epinephrine, norepinephrine, or dopamine, okay, or simply block the reuptake. So those neurotransmitters stay acting there for a longer time. And blockers, okay, are the ones that may block either or these receptors. Okay, and there is another way that our body can decrease the actions of the sympathetic nervous system or parasympathetic is by increasing the number of receptors or decreasing them. And that's why, for example, people who have addictions to some substances, they need to increase the dose. Okay, they start one night taking a pill of ecstasy or something that stimulates the release of dopamine, but then the neurons that are on the other side receiving the rain of dopamine will say, no, this is not good. And they reduce the number of receptors for dopamine. So next time when they take one pill, this is mixed with something, this doesn't have any effect. Let me have another. Oh, now I feel better. Because now you need twice as much to get the same effect. But the neurons on the other side say, no. They reduce the number of receptors, and now they need 3 pills, and then 4 pills, and then 5 pills. Okay, and the body gets used to that, and that increasing dose, and the body adapts. Homeostasis working, allostasis, allostatic overload. And unfortunately, what happens in many cases, you've seen many famous people, celebrities that die of overdose. Maybe it's not an overdose. Maybe they were used to take 10 pills per day. And then they go to a rehab clinic. 6 months there, they have money for that. And they are 1 year, 2 years without taking any substance. They were taking 10, remember. And one day they feel bad for any reason. Let me take 5. That's a lot. No, because during those 2 years, the neurons already upregulated other receptors. Oh, there is no rain of dopamine. Now when you take 5 pills, okay, half of the dose they were taking previously, they die. Because that is a surprise for the body. Okay, and that's one of the reasons why that happens. And well, this is all for this week.
Professor, you said they upregulate like the amount of receptors. For example, in ecstasy, they increase the amount of receptors for dopamine.
That happens with any, not only with substance of abuse, or that happens with any medication. Okay, that our body either down-regulates or up-regulates the receptors to try to adapt.
With alcohol as well. I mean, there's people that, they drink a lot and don't get as drunk.
That happens with anything.
They stop drinking and then
Yeah, that happens with anything. Okay, so
In regards to Monday's test, what